practice.
Just to remind you too, if you have any questions for Dr. Hawkins, his is a green form, if you could write that out, and then we'll come up and pick those up.
Well, good evening. Thank you, Brian, for introducing me. So Brian has a large practice, major surgical treatments that he does for his patients, both oncological, and he also treats male as well as female incontinence, and does quite a bit of pelvic reconstructive procedures. My practice is more so in the neurourology area, where the bladder dysfunction, it's not only the leakage, but you also have other problems with the bladder. You may not be able to pee, and there may be retention, which is not really a mechanical problem, so they're bladder muscle problems, which I can fix. There are also bladders which are overactive, so you get urgency, frequency, and urgent incontinence, like he explained to you guys. And those can be fixed with a lot of different things. So we'll go through a few other things. And once again, if there are any questions, keep them towards the end, and we'll answer all the questions. So here are some slides that I'll show you, and we'll go through in detail as we go, about female stress urinary incontinence. So there are three types of incontinence, like Dr. Hopkins explained to you guys, and they are stress, urge, and mixed urinary incontinence. So we're going to describe those. We'll give you an overview of the stress urinary incontinence, and then we'll give you the treatment options. So bladder leakage, there's no explanation. Everybody knows what the bladder leakage or urinary incontinence is. Bladder leakage is also known as urinary incontinence. It is loss of bladder control or involuntary urinary leakage when you do not want to urinate. So 1 in 3 adult women will have urinary incontinence. Less than 50% of women with urinary incontinence discuss their problem with the doctors. While the main problem is embarrassment, they usually think, well, we are older, and this is part of life, that we'll leak a little bit and make some company with diapers rich and buy those, but that is not a solution. In 2013, the one take-home message is we can make everybody dry. Whatever type of incontinence you have, whatever type of bladder dysfunction you have, how many treatments you've had before, we can always do something to make you better. It may not be 100%, but we'll make it much, much better than where you are. So the other thing is that they think the symptoms are due to aging, which is not again true. There is, aging is a factor, but it's not that it's inevitable that everybody's going to leak urine and will wear diapers. You can still have good quality of life and do not have to wear diapers. So the three types of incontinence is similar incontinence you have in males. Dr. Hopkins described it very well. And the first one is urge incontinence, and that is got to go, and oops, I went. And that is an urge incontinence. The stress incontinence is, well, you cough, sneeze, and then there's oops, I leaked. So that is stress incontinence, where you increase your pressure in your stomach, in your abdomen, and that pressure makes you leak. But it is not an urge. The other one is urge incontinence, and that is, again, like you described to you, the key in the lock syndrome. When you get home and you're putting a key and it kind of gets stronger and stronger, you turn your tap on, it gets more stronger. So that is all urge incontinence. But you'll see a lot of people will have a mixed type of incontinence. So they have some stress, they have some urge, and that's how those incontinence are. So if we stratify that, you'll see that about 11% females will have urge incontinence, about 50% will have stress incontinence, and the rest of the people will have something called the mixed urinary incontinence. So the urge incontinence is often described as, I said, got to go, and I went. And the treatment options there are very simple. So most of the time, if it is not a major problem, dietary restrictions, dietary changes, fluid balance, bladder retraining, and exercises. they really do a lot of good to you if you learn them and do them properly. So Linda is really expert of that, and we send a lot of patients to her. You can do surgery, you can give them medication, but if you do not do these things, the incontinence will not improve. So dietary changes, fluid restrictions, bladder retraining, and exercise is part of any regimen, whether you take medicine, whether you don't take medicine, whether you have surgery or you don't, these are still necessary. Biofeedback training is, again, a lot of it is done in Linda's clinic, and she does the biofeedback training where they teach. Some people cannot do the proper exercises, so we teach them with some electromyographic machines how to train your muscles so you get better control. Then again, surgical options are still there for overactive bladder as well. And mixed urinary incontinence, again, you got to pick and choose which one is predominant and treat that first. So is it stress, is it urge, and then you treat it that way. So let's talk a little bit about stress urinary incontinence, which is incontinence due to increasing of pressure and leaking and not being able to control the bladder with your body movements, exercises, coughing, sneezing. Even just getting up from the chair, sometimes you'll start leaking because your urethra cannot control it, or your sphincter cannot control it. So what are the potential stress urinary incontinence risk factors? Well, first, of course, comes is age. Now, age, what do we mean by that? That is, after especially in ladies, postmenopausal, you lose your hormones. So when you have your hormones, your mucosa in the genital area is pretty puffy, and it blocks, it puts a water seal. As you age, that goes away, and the mucosa atrophies, and you start leaking because you need more force to control that. And with age, of course, your muscles go down, so you can't control that. So all that is part of aging, which causes it. Then, of course, vaginal deliveries. If you've had a few babies who are 9 or 10 pounders, well, that makes it, and that causes problems. But also, a lot of people are getting cesarean section and thinking, well, they're not going to get incontinence, but it still happens. It's the head of the baby, which is in the pelvis. It causes neuropathy in the pelvic nerve. So it's not just stretching, it's also nerve damage due to just the head being there and then contracting and causing some nerve damage. All that can be corrected if you start doing your Kegel exercises in time. So the next one is obesity. Of course, if there is more weight, when you stand up, more weight falls on your bladder, and bladder doesn't like it. It's already overactive, or it can't control. The weight adds to it. Hysterectomy, there, if you do an extensive surgery in the pelvis, you denervate the bladder, and that causes problems. And of course, physical activity, smoking, family history, and family history is important. So now there are lots of papers that came out that if the grandma had a stress incontinence surgery, the mom is going to have, the daughters are going to have. So it does run in the families. Mostly it is related to prolapse. Then that is because of the pelvic muscle weakness that causes prolapse. And there are lots of other medical conditions which can also add to it. So what can we do? What are the treatment options for stress urinary incontinence? Of course, non-surgical treatments are the ones which are tried first. So they include pelvic floor muscle training. And that is really a serious thing. It's not just doing Kegel exercises. A lot of ladies come to my office and they're doing Kegel exercises, contracting their abs, contracting all other muscles, except the one which needs to be contracted, that's the sphincter muscle. So we need to teach, we need to train, and that is our continence center. Linda she's a great expert on that. So if you have any problems with that and you need to learn exercises, contact her and she'll be very happy to teach you how to do real good Kegel exercises. Bladder training is very important there too. You need to know how much fluid to drink, what kinds of fluid to drink, when not to drink. I'll give you a great example. I had a patient last month. He came to me, it's a male patient, came to me and said, I can't get away from the bathroom. I said, okay, well, we got all the history, got everything, and I always get a bladder diary on those patients to chart down how many times you pee, how much during the day, and what volume during the night. And that gentleman was drinking 5,000 cc, that's 5 liters, 5 quarts of water in 24 hours. I said, simple math, I don't have to treat that, so divided by 24 hours, you got to be in the bathroom every half an hour, with 500 cc of urine. So simple thing, like he said, but I'm flushing my kidneys. Isn't it good for me? I said, it's good, but don't overdo it. So you need to learn how much water to drink, and that helps. That helps a great deal. So bladder diaries help me a great deal in knowing how much what you do at what time at home. And same thing on prompted voiding. So a lot of problems happen in younger age. Young ladies, young girls going to the high school don't like the bathroom, so they're not going to go all day long. They hold their urine, come back home and pee. So they pee in the morning, they pee in the evening. And meanwhile, the bladder distends, it gets overactive, it gets thick-walled, and it gives rise to a lot of problems. And that continues throughout your age. So a lot of those behaviors can also cause a lot of problems. Now, there are lots of surgical treatments available, so we always try the exercises, bladder training, and dietary and fluid balance treatments. But then if those don't work, or do you need further treatment, your leakage is not improved, then of course we do one of these surgical treatments, and they are very, very effective. So the surgical treatments I mentioned here on the slide are open retropubic suspension called the Birch suspension. It used to be the gold standard about 20 years ago. I don't think a lot of people do that anymore, but this can be done laparoscopically, it can be done robotically now, so it is back, but in a different way. So it's done much more simpler way, less invasive way, but it's effective in those cases. Sling procedures are very common, very, very effective. So this slide shows how do you get the stress incontinence. So this is a normal pelvic anatomy. Here's the bladder, that's the pubic bone. So this is kind of the side of a female pelvis. That's the urethra there. And like Dr. Hopkins told you, there are two sphincters. In female patients, the sphincter is right here on the bladder neck and the external sphincter here, and not too far apart. And the external sphincter is actually the main sphincter that controls. In men, you're lucky you got two, but in females, we got only one sphincter. That's why there's more incontinence too. Right behind is the vaginal canal, and then above it is the uterus. So all these organs in that area can affect what we do, how we fix incontinence. So bladder, urethra, sphincter. And what anatomical changes occur when we get stress incontinence? Once again, there's bladder and there's the urethra. And in the previous slide you saw it was kind of angled. So the bladder was here and the urethra came at a little angle to it. In older age, and when you have delivered some babies, this muscle tone goes down and the urethra becomes pretty straight. So when the bladder is pressurized with coughing, sneezing, exercising, or there's no blockage and the urine flows right out and you can't control it. So to get this anatomically correct, once again, then you need surgery to fix that problem. And we also put a sling to control the urethral region. So it's kind of a hammer right below it. That's the urethra, and the sling goes like that. So it corrects the angle. It also gives some support. So when you cough and sneeze, the urethra doesn't get straight, but it gets blocked by that hammer or the sling, so you don't leak urine. And they are very, very effective. And it is a surgical procedure. It's a small incision that we make. And we put in a mesh. I know you guys must be having a lot of questions about mesh, because that is being advertised on the TV and everywhere, that mesh causes a lot of problems. Dr. Hopkins can tell you, and I can tell you, I've been practicing this for 30 years. The mesh erosion, the mesh problem rate is between 1 to 1.5, maximum 2%, depending on how much mesh you use. So it is not that great. If you operate 100 patients, 1 or maybe 1.5 or 2 patients might get some problem with it. And that is usually a minor problem. If it does expose, you remove that part, the rest of the part still works. So it is not that major an issue like it's been brought forwards in the media. So the complication rate is pretty low. So the mesh sling, which is the treatment for surgical option, how does it work? Like I explained to you, it is kind of a hammer. So there are two types of slings that we put in. One is called transobturator, pretty similar to what Dr. Hopkins explained to you. It is a very, very minor procedure, or a mini arc sling. So those slings go below the urethra, but we do not anchor them anywhere. So previously, when we put slings in, we anchored them to the tissue, so there was a lot of pull on the urethra. So the chances of the person going in retention or not being able to urinate afterwards were high. With these slings, we don't pull them, they just merge with the tissues on the sides. So the complication rate, which was there with retention, is much, much lower. And a lot of slings have been done. I think 1 billion burgers are sold and 1 million slings are done. That's what McDonald's is, right? So see the success rate is very, very high. Success rate is 85 to 94%. Some people will say, oh, that's not high enough, why is it not 100%? Well, we are treating with mesh. We can't regenerate the tissues in the female patient. So if the tissues are bad, they're not really going to hold. And 10 or 15% people will get some problems afterwards. Now, majority of the patients will get drier. I would say drier. So they may not be completely dry, but they will get drier. But you will see that about 50–60% people don't need pads anymore, don't wet themselves anymore. And a lot of times you treat the stress incontinence, the urge incontinence goes away on its own as well, because now the bladder can empty properly, and it's not holding too much urine, and it's not overactive anymore. So a lot of problems will get solved with the slings. So what are the warnings with the procedure? Like I talked to you, that there are inherent complications. The surgical procedure is a surgical procedure. There are inherent complications, but overall complication rate is very, very low. Now what can you get in the complications there? Well, you can have a little pain. Of course, pain is going to occur. There's a small incision, especially if we put any transoperative tape, there's a little groin incision as well. And the mesh can erode, but once again, as I said, the mesh erosion rate or the mesh exposure rate is 1 to 2%, very, very low. Fistula formation is kind of non-existent. It used to happen when you used to have a repeated sling. So it happens in people who have already had 1 surgery done or 2 surgeries done, and they still leak, and they do a 3rd surgery, but there are not very many tissues to cover that area, and then you can get problems with that. But otherwise, it's very rare. Adhesions and urinary incontinence involuntary, that is again inherent problem. A bladder which is leaking continuously has no control over it. Now we put a little barrier. So the bladder can get overactive at times. So about 15–20% people will get what's called urgent overactive bladder afterwards and may need some medication. So what are the other warnings? Urinary retention. Urinary retention used to be pretty high complication rate after the slings, and that was 5 to 10%. And in birch suspension, because the pull was so strong, it could be even higher, and the patient needed catheters. Sometimes we need to take the sling out. With new type of slings that we put in with mesh, there's really no tension. These are almost tension-free slings. So there's no tension on the urethra. It's just like a little hammer. So only when the urethra sags that it stops it. It's not pulling, it's not compressing the urethra. So the complication rate on retention is very low. And the other complications listed here are again very, very uncommon, except for the patients who have had surgeries before, pelvic surgery, multiple incontinence surgeries. Then you can injure the organs around that urethra or the bladder, but otherwise it's very uncommon. So in summary, learn about your condition of stress urinary incontinence or even urge incontinence. Talk to your physician about your symptoms you are experiencing, and then see a physician that really specializes. So in our practice now, Dr. Hopkins specializes in male incontinence. I specialize in a lot of female and neurological incontinence problems. We have 2 other physicians who also specialize in other areas. So seek a physician who is expert in those so that they can tell you what the problem is. A lot of people will not investigate these patients, like Linda does very detailed urodynamic study for us before we do any incontinence procedures. We exactly know what type of incontinence there is, and then treatment gets easier. Well, thank you very much, and then I'll have Linda talk to you guys. Linda is in charge of our continence center. I direct the centers. I'm the director. Linda is in charge, and she's the whole soul. She runs the center, and she is a great expert in continence. Any continence issues, she can answer it, and she can fix it.